Hi, this is Mark Struthers. Today we'd like to talk about chest tubes and pneumothorax. We'll look at image acquisition and we'll also look at the procedure itself. With pneumothorax, we look at three types of pneumothorax: the closed pneumothorax, the open pneumothorax, and the tension pneumothorax. Of these, the tension pneumothorax can be life-threatening and is an emergency. Here we have a view of a pre- and post-chest tube insertion. On the floors or in the ER, most of these exams are taken with the portable chest unit. In the emergency room, the portable chest is taken first, and then we do a E-fast ultrasound. Let's see if we can make some sense out of these images. Ultrasound is a non-invasive immediate tool used to image tissue. It will not penetrate bone like an X-ray. So the first step to help you read the ultrasound image is to be familiar with the anatomy that you are imaging. Various tissues conduct sound differently. Some tissues absorb sound waves, while others reflect the sound waves. The density of the tissue dictates the speed at which the echo returns to the transducer. The X-ray transducer or probe both sends out the signals and receives the signals in return from the body. A demonstration of this is what we call the bat view. Obviously, the shades of gray or shadows look like a bat. We can see the superior rib, the inferior rib, and the chest wall in between, including the pleural line. No, this is not a chest ultrasound, but an ultrasound of a fetus. We want to use that as a demonstration to take a look at the difference in the shades of gray from bone to tissue to fluid. Notice that ultrasound imaging does not work well with gas, so organs that are filled with gas or air, like the lungs, are generally not examined with ultrasound unless we're looking at an emergency situation. That is why we always get a combination of a portable chest X-ray and a fast scan in the emergency room. When examining an ultrasound, if you remember that fluid is always black and tissue is gray, and the denser the tissue is, the brighter white it will appear in ultrasound, and the brightest white being bone. There is a protocol for examining X-rays, and there is also a protocol for examining ultrasound. And the first part of that protocol is you start from the top of the image. The top of the screen or printed image is where the ultrasound probe was placed. As an X-ray, most of the images are mirrored, and they will have the right and left markers on them. We use a very simple setup in the emergency room when we use sonography, because there are many different visual effects that can happen as a result of the ultrasound setting or angle or the density of tissue being examined. We want to get the fewest variables possible while we're imaging. Some of the most common visual effects to watch for include enchantment. This is when a part of a structure being imaged or examined appears brighter than it should due to an excess of fluids in the area, such as an cyst. Or attenuation, also known as shadowing, and this effect causes the area being scanned to appear darker than it should be. And finally, we get anastropy. This difficult effect has to do with the angle of the probe. For example, holding the probe at a right angle to some tendons would cause the area to appear brighter than normal, so it is necessary to adjust the angle of the probe to avoid this effect. Let's get a closer look at these different types of effects used or seen when you're using ultrasound to visualize tissues in the body. If we see something on the original scan, we can turn our ultrasound into M mode. In other words, if you see something on the original scan, you can go to M mode to define what you're looking at. The normal lung demonstrates the skin, muscle, pleural line, and lung artifact. The muscle is known as the ocean, and the lung artifact is a picture of the sand on the beach, which means this is normal. You're looking at waves and something that looks like sand on the beach. Now let's look at a pneumothorax. Again, we see the skin, muscle, pleural line, and lung artifact, but the muscle now looks like a barcode sign. And so we know that we have a collapsed lung because there's nothing there. This is a sign for the presentation of a pneumothorax. A hemothorax can easily be distinguished on normal ultrasound, and you don't need to go to M mode. So let's take a look at a left pneumothorax. We can see the collapsed lung, and we can see the absence of lung markings. And we can also see with the pressure of the collapsed lung, the mediastinum has been pushed over. We'll start by looking at the pneumothorax, then the initial repair, and the subsequent condition after the tube's been inserted. Pneumothorax is defined as the presence of air or gas in the pleural cavity. The clinical results are dependent on the degree of the collapse of the lung. It is very difficult to see a small pneumothorax on a chest x-ray, and usually with a small pneumothorax, the air leak will resolve itself in a matter of time. If the patient is unstable, hypoxic, or the pneumothorax is large, then the pleura is drained with a catheter or a chest tube. A large pneumothorax is 25% of the lung area or greater. On the left, we can see the small amount of tissue, which is the collapsed lung, then the absence of lung markings, and a shift of the mediastinum. Notice we said 25%. You'll notice that we look at chest x-rays and we gauge the amount of the collapsed lung by the percentage. We can have a traumatic pneumothorax, or we can have one of two types of spontaneous pneumothorax. There is a primary spontaneous pneumothorax that occurs in individuals with no known lung problems. It is often seen in individuals that are tall, thin males and can be influenced by such factors as smoking, scuba diving, or high altitudes. The secondary spontaneous pneumothorax occurs in individuals who have known lung disease or medical conditions, such as cystic fibrosis and COPD and emphysema. The main symptoms of a spontaneous pneumothorax include a sudden chest pain and shortness of breath. The severity of symptoms may depend on how much the lung is collapsed. Recovery time varies depending on the severity of the condition. It usually takes 1 or 2 weeks to recover from a pneumothorax. A small pneumothorax may heal on its own, while the larger one might require medical intervention, such as the insertion of chest tube to remove the air from the pleural space. There are different types of chest tubes, and they all have a designation as to their size in French. A hollow plastic tube is inserted between the ribs into the pleural space. It may be connected to a machine to help drainage. The placement of the thoracostomy tube is into the 5th or 6th intercostal space anterior to the mid-axillary line. Chest tube insertions are often an emergency, life-saving procedure, especially if you have a tension pneumothorax. Depending on the urgency of the situation, the procedure may be performed at the bedside, in the operating room, or in an interventional radiology suite. After insertion, chest tubes are usually connected to drainage systems.